Hey, this is Michael White. I'm going to give my perspective on approaching patients and how I think about patients when I see them in the emergency department. So, again, this is just my opinion, my approach. It doesn't mean you have to follow it, but it's kind of how I think about folks. So, when I see a patient, I put them in one of three buckets. And by that I mean I think, are they going to be a discharge, are they going to be an admission, or are they going to be a transfer? And the reason I do this is, for example, if it's going to be a transfer, then the patient needs to get to the receiving facility and I start making my calls early. If it's going to be an admission, that changes my approach to ordering because I'm no longer ordering for myself, but for the hospitalist, and I tend to order more broadly. And then if it's going to be a discharge, the question in my mind is, what do I need to do to get the patient home safely to rule out an emergency? With all of these, especially admission and discharge, I have a shared decision-making discussion with the patient. For example, let me say that I'm worried about somebody with a sprained wrist, and I talk to them about options, and they want an x-ray of their hand. Not a problem. I'll do the wrist and the hand. If they want an MRI, that's not going to happen out of the emergency department, and I have the discussion of why that's not going to happen. So I try to address each of those things with the patient, similar with the patient for admission, the discussion up front, and this has happened countless times where somebody shows up and they have chest pain and they have a lot of risk factors, and I tell them I want to do this, that, and whatever, and then admit them to the hospital. And there's been a number of times patients have said, I just want an EKG and then I want to go home. And I have a discussion with them about the risks of that, and I do a partial AMA and put the documentation in the chart, unless, of course, the EKG shows a STEMI, and then we have a different conversation. But I really try to incorporate the patient into what I'm going to do. At the end of the day, is their body, is their care, and I'm trying to deliver the best to them, but I need to work in concert with what works best for them. So discharges, I tend to think in my mind when I see somebody how long they should be in the department, because that's going to help me remember to drive the patient through. So if I think they're going to be a short stay, like a prescription refill, then I'm going to be bird dogging to make sure registration is doing their part to get them all out of there. If it's going to be a wrist x-ray, similar kind of thing. I'm going to be watching for that x-ray to come up. If it's going to be a longer length of stay, let's say a kidney stone I think can go home, then I'm keeping in the back of my mind how long I think a CT should take to come back before I have before I start fussing at CT about getting me those results. So I try to set that up in my mind ahead of time when seeing a patient. It also helps me talk to the patient to set expectations for how long they're going to be in the department, and I try to have that conversation with the patient. Of note, one of the things I do to risk mitigate is I try to do three things during each stay, unless it's like just a prescription and go home. I see them in triage. I try to catch them halfway during their workup, discuss any results that are back, make sure they're doing okay. And then I personally like to discharge my own patients and have them sign the paperwork and answer any questions they have. I make the analogy to a waiter. When I go into a restaurant, they greet me and bring me my water or whatever, take my order, come back about halfway through, make sure the food's okay, and then at the end they come, check in on me, give me the check, make sure I don't need anything else, and then I go home. So admissions, similar to discharges, I tend to branch them into length of stay. If I think it can be a shorter admission length of stay, let's say like a chest pain, then I keep in the back of my mind what I need to admit the patient. And again, this has to be in concert with the hospitalist. For example, there's plenty of literature that shows if you get an EKG and there's no STEMI, but you want to admit for high-risk chest pain, then you do not need an enzyme, because the management really shouldn't change based on a single troponin level, because you don't know if it's up or going down. However, it depends on the hospitalist and having that conversation with them. Like transfers, I talked about getting transfers out early. I like to communicate with my hospitalists, often through text, and just give them a heads up that I have an admission coming for them, because sometimes they have time earlier in the day and they can come get the patient admitted to the hospital instead of having them wait countless hours when they're busy later and can't get to the patient. So I give them a heads up, let them know that it's coming their way, and come get it now, come get it later, whenever. If they're going to come get it later, I don't put an admission disposition in until I'm complete with the admission. Sometimes they just come down and see the patient and get them admitted because they can get more consultations earlier in the day, and therefore their overall length of stay drops down. In my experience, if I admit earlier, it reduces admission length of stay by approximately half a day. Transfers, again, we've got a lot of things going in one direction, but if you're going to transfer, you need to get them out and heading to the place where they're going to receive definitive care. If you're transferring, that means you don't have the definitive care, and they need to get to the place where they can get that. There's no reason to keep them at your place. So the last category, I talked about admit, discharge, and transfer. The last one is undifferentiated. It's kind of like this salad here. There's a lot of different things there. You can't really tease out and figure out which one you want to go for first. Undifferentiated means that you're uncertain if you want to do admission or discharge or transfer. And so what very often happens is I will order as if I'm going to admit to the hospital, and then wait for all that stuff to come back. And it's just an approach that I found that works, because if I'm uncertain, there's a chance that they'll be admitted to the hospital, so I might as well order along those lines. Clinically, this is what I have in the back of my head. I want to see them within 5 minutes, and then there's the various steps in terms of evaluation and getting the patient in and out based on whatever I'm going to order, and then there's the overall length of stay. So I've talked about this a number of times. Patient arrives, we receive and evaluate in the triage room, which means that we are not the doc in the back and the backs. In the back where we can't get to the patient, we should be at the front. You can't be a leader from the back. If they're high acuity, they go to a high acuity bed, and I usually just have that conversation with my triage nurse or with my charge nurse. If they're intermediate, they can go to the care area, which is essentially a assembly line to get stuff done. And if they're low acuity, they can go over to get their testing and then out to registration or the outer waiting room, waiting for the results to come back. And again, these patients in the intermediate and low, I tend to bring back into my room and discuss the results with them so that they know what's going on. And I think that delivers best care. So I do my throughput based on duration, not by acuity. So when I see somebody, I think about how long they're going to be, and then I keep that in the back of my mind. And if my results aren't coming back, I'm bird dogging things, trying to figure out why and to get the patients out. One other key is if you have a female and she's between the ages of 13 and 55, is what most places do, they don't leave my triage room without a urine specimen for a pregnancy test or a waiver. Even for a hysterectomy, they should sign the waiver saying that they understand the risk and that they're certain they're not pregnant. Thinking about advanced practice practitioners, I love our PAs and nurse practitioners. However, they have to have a approach to patients, and it's really a three steps. One is they see somebody, they think they got it, like a stubbed toe, and they can independently evaluate that patient. Of course, they're not truly independent. We're always supervising. Step two is, let's say they're new and they don't know about sepsis. They may ask you about a consultation on a patient. But that doesn't mean they're gonna turn them over. However, there's a number of times when they consult me, I go see a patient, and then I take the patient over because I think I can deliver better care just based on my experience. It has nothing against them. It's just a question of what is best for the patient. And then the third is the mid-level comes to me and says, I want to turn these over. I always accept these patients, pretty much. I mean, sometimes if I'm swamped and getting killed, I will ask them to continue care, but I will give them heavy guidance. So here's kind of a breakdown. APC evaluates a new patient. They determine their comfortability. meaning do they have capacity? Are they too overwhelmed in capability? Are they able to take care of the patient? As long as they have capability and capacity, then they can make a determination. So if they're comfortable alone, then they take care of the patient, do the disposition. If they're comfortable with consult, then they come and they're responsible to come talk to us. And if they're uncomfortable, they turn it over. Now, when they turn it over to me, I have a discussion with them about the note. I hate pit notes. What a pit note is I saw them in triage, and they're just dumping the whole thing on you. Personally, I often like them to chart if I like the way that they chart, and I'll ask them to do that, and then I'll take the patient over and complete the charting. And that gets me through the basic part of the charting, the HPI, a review of system physical exam. We also have a discussion about orders, because if I'm tied up and I want them to put in orders, I'll ask them to put in orders, and then I will assume care of the patient. But somebody clearly needs to own each patient in the department. There is no such thing for me as we are co-managing. Either I am leading it or they are leading it, but somebody is responsible so that the patient clearly knows who is their caregiver, and the nurses know as well. Hopefully this was a helpful short approach on how I look at patients and approach them. Thank you.